What's up? Medite here, and in this video, we're gonna go through the anatomy of the large intestine. So in the last video, we went through the anatomy of the small intestine. Now, the next step after the small intestine is the large intestine, as you see here. So in this video, we're first going to go through the different parts of the large intestine, as well as the topography, basically where the different parts are located in relation to the surrounding structures. Then we will go through the layers of the large intestinal wall. So here I've highlighted the large intestine, or Intestinum Crassum in Latin. Crassum means dense or thick. It starts at the end of the ileum and ends at the anus. So the whole colored part is the large intestine. And so if you would stretch out the large intestine, you would see that it would be approximately between 1 to 1.5 meters long. So it's not as long as the small intestine, and its functions differ. The primary function the large intestine has is absorption of water and electrolytes. And if, for instance, the bolus or the content passes through the large intestine too fast, or the absorption of water in the large intestine is altered, you will get a really watery feces. That'll be the case of diarrhea. So now, the first parts of the large intestine are the caecum and the appendix, closest to the ileum of the small intestine. And then we have something called the colon. And the colon are divided into parts. We have the ascending colon, which goes up. Then the transverse colon, going horizontally to the left. Then there's the descending colon, it goes down. Then there's the sigmoid colon, which curves a little. And then lastly, we have the rectum. So now, let's go through each of these parts in detail, starting down here, at the caecum and the appendix. So as always, I like to start with the topography, to have the orientation right. So let's do the holotopy first, which means the location of an organ in relation to the body as a whole. So the caecum and the appendix lie in the right inguinal region, as you see here. So any localized pain in this area, think of the appendix or the caecum. Now let's start with the anatomy of the caecum first. The caecum is about 6 to 8 centimeters long and about 7 to 7.5 centimeters wide. And so the caecum is the connection point between the small intestine and the large intestine, right? So if we change up the angle a little bit, you will see a hole right here. This hole is called the Ileal Orifice, connecting the ileum with the caecum so that the small intestine can release its content into the large intestine to be processed further and then secreted out. But here's a cool thing with this hole, is that it's controlled by this valve called the Ileocecal Valve, which is a sphincter muscle valve that separates the small intestine and the large intestine. And its critical function is to stop the content inside the large intestine from going back into the small intestine again. You don't want the content here that goes into the large intestine to go back into the small intestine again. You want it to go outside the right way. So that's the caecum. Now going over to the appendix, or Appendix Veriformis. Veriformis means worm, since the appendix has a worm shape. That's where the Veriformis in the Appendix Veriformis comes from. The appendix is about 2 to 4 centimeters long and about 0.5 to 1 centimeters wide, so it's a very tiny organ in the body. The appendix connects to the caecum through an opening at the top here, called the orifice of the Veriform appendix. Now the appendix may be found in different positions. And this is very important to keep in mind as you're studying the appendix clinically. So the normal one is the caudal position, as you see in this picture. You will find it in the caudal position in about 40 to 50% of the time. And in some other people, in 17 to 20%, you will find it in the medial position, going into the promontory of the sacrum. And 17 to 20% again, you will find it in the lateral position, towards the inguinal ligaments. And then in some other people, in 9 to 13%, you will find it going posteriorly behind the caecum. And then really rarely, you will find it going anteriorly in front of the caecum. Sometimes, and it happens pretty often in patients unfortunately, inflammation of the appendix may happen, and this is called appendicitis. It's a very common cause of acute severe abdominal pain. If the appendix is not removed or treated, it can become necrotic and rupture, resulting in peritonitis, which is inflammation of the peritoneum. I will talk more about the peritoneum in a separate video, but if it ruptures, all the bacteria from the appendix will get into the peritoneal space, which is all the blue area here in this picture. And in a pretty severe case of appendicitis, the abdomen is usually tender at McBurry's point, which is on the right lower side, as you see here. But what's interesting here is that many miss this throughout their clinical practice, and early appendicitis is usually felt centrally within the abdomen, and that is because the sensory fibers from the appendix go through the sympathetic nerve fibers and enter the spinal cord at T10, which correspond to the umbilical dermatome, as you see here. So for the patient, pointing where it hurts is a hard thing unless the infection is severe. In that case, we gotta have to diagnose it further. That was a little taste into clinic as you're studying the anatomy. So that was all the anatomy of the caecum and the appendix. Now let's do the ascending colon. The ascending colon is called the colon ascendens in Latin because it ascends, as you see here. It stretches between 12 to 20 centimeters long and reaches up to the inferior surface of the liver. And if we look at the topography of the ascending colon, we will start with the holotopy again. Holotopy, remember, is the location of the ascending colon in relation to the body. And you will see that a significant part of the ascending colon lies in the right lateral region. But at the region where it bends, also called the right colic flexure, that one will be in the right hypochondriac region. Now, if you turn this picture to the side, just like this, we will now look at the syntopy, meaning its position to other organs. So anteriorly, you will find the anterior abdominal wall, laterally, the lateral abdominal wall, but posteriorly, you will find the quadratus lumborum muscle, as well as the right kidney behind it. But there's actually one more muscle you will find behind the ascending colon. And that's if we add the transverse abdominal muscle, you will find this muscle originating from the backside of the body. So you will find this muscle as well when you look at the different structures behind the ascending colon. So that is the ascending colon. Next, we have the transverse colon. And if we go back to this picture again, the transverse colon is here. And the length of the transverse colon can vary a lot. It can be between 30 to 80 centimeters long, which means that the transverse colon is the largest part of the large intestine. Now let's get into the topography of it. Adding the lines, you will see that the transverse colon starts from the right hypochondriac region with the right colic flexure. Remember we talked about this one. Then the transverse colon curves a little downwards to end in the umbilical region, and then goes upwards again and ends at the left hypochondriac region where there's another curvature called left colic flexure. And what's interesting with these two flexures is that you will find the left flexure a little bit higher than the right flexure. And if you look at its position in relation to the vertebrae, you will see that the right flexure lies in the region of the second lumbar vertebrae, while the left flexure is at the level of the first lumbar vertebrae. So the left one is slightly higher. The reason why the left flexure is higher has to do with the fact that there's a ligament holding the left flexure of the colon and pulling it higher than the right flexure. So let's visualize that by adding a perfectly drawn diaphragm. You will find the left colic flexure connected with the diaphragm through this ligament right here, the phreno-colic ligament. And if you remember the word phrenic has everything to do with the diaphragm. That's why it gets the name phreno-colic ligament. It holds the left flexure up and connects it with the diaphragm. Now the transverse colon is fixated in place, very similar to the small intestine. And it's important to mention it here because it differs from the rest of the large intestine. So let's make a vertical cut and look at a sagittal view of the abdominal cavity. You will see this, right? So the transverse colon is right here. And just for orientation's sake, you will find the stomach and the liver up here and the small intestine down here. Now the transverse colon is fixated. It's attached to the posterior abdominal wall through the transverse mesocolon. Now I'm not going to go into too much detail about the peritoneum yet, since that's for another video, but the peritoneum is a fatty layer that protects and fixates the organs in place within the abdominal cavity. And there's something called the greater omentum, which goes down from the stomach, curves, and then completely wraps around the transverse colon to then form the transverse mesocolon, which anchors the transverse colon to the posterior abdominal wall. And don't confuse it with the root of mesentery, which anchors the small intestine to the posterior abdominal wall. Don't worry too much if this went too fast. You will see this again when you study the peritoneum. Now, if you look at the transverse colon anteriorly again, and look at the syntopy of the transverse colon, meaning its position to other organs, you will see that superiorly you will find the liver and the stomach and the spleen, and then inferiorly you will find the rest of the small intestine, and then posteriorly you will find the pancreas, as well as the descending part of the duodenum. So that is the general structures of the transverse colon and the topography as well. Now let's do the descending colon. So let's go back to this picture again. The descending colon is right here. It's about 15 to 20 centimeters long, and you will find it in the left lateral region, lying in the left iliac fossa. So the lower part of the descending colon lies in the left iliac fossa. And it connects with the sigmoid colon. And so let's look at the descending colon at a different angle so that we can look at its relation to other organs. Anteriorly and laterally, we have the abdominal wall. And then medially, you'll find the small intestine. And then posteriorly, you'll have the same structures as the ascending colon. You will find the kidney, the left one this time, and the quadratus lumborum. Another thing you need to know about the ascending and the descending colon is that a huge part of the large intestine are entirely surrounded by the peritoneum, except for the descending and the ascending colon. And I'll try to visualize that for you. So if we make a transverse cut and look at it from this view, you will see this picture right here. We call the ascending and the descending colon the mesoperitoneal viscera. And they're mesoperitoneal because they're partially covered by the peritoneum, as you see here. It's only covered by the peritoneum from 3 different sides, in contrast to things like the transverse colon and the rest of the small intestine, which are entirely surrounded by the peritoneum, and we call those the intraperitoneal viscera. I'll talk more about these in detail when we talk about the peritoneum, but for now, keep in mind that the ascending and the descending colon are only partially covered by the peritoneum. So that is the descending colon. Now going over to the sigmoid colon, so let's change the picture again. The sigmoid colon is right here. It can be everywhere between 15 to 80 centimeters long, so it varies a lot as you see. It might be long or it might be short. In some people, the sigmoid colon can even get to 1 meter long, so keep that in mind. It can be short or it can be long. So a huge part of the sigmoid colon lies in the left iliac fossa. It goes downwards, and then at the level of the sacroiliac joint, it bends backwards and then continues to then become the rectum. So let's make a vertical section again and look at a sagittal section of the abdominal cavity. Remember, we already went through all of these structures, but the sigmoid colon, which is down here, you will find it being fixated to the posterior abdominal wall through the root of mesentery, together with the small intestine. So that was the sigmoid colon. Next we have the rectum, and so let's start by looking at it anteriorly, right here. It's about 15 to 20 centimeters long, and it kind of has an S shape, as you see here. It has some curvatures. So superiorly, it's connected with the sigmoid colon, and looking at it from a slightly different perspective, this is the posterior lateral perspective, you will see that it lies right in front of the sacrum. And so let's now make a vertical cut of the rectum to focus on the curvatures. So the first curvature is the sacral flexure, because it lies in front of the sacrum. And then we have another flexure called the perineal flexure. The perineum is the region between the external genitalia and the anus. So this is called the perineal flexure because it lies in this space, in the perineal space. And so the upper part of the rectum, in front of the sacral bone, we call this place the rectal ampulla. And the rectal ampulla is about 10 to 14 centimeters long and 7 to 7.5 centimeters wide. And what's interesting with the rectal ampulla is that if this space would be full, you'll have the feeling that you need to poo. And then the lower part of the rectum is called the anal canal. The anal canal is 2.5 to 3 centimeters long and 2.5 centimeters wide, and is also the last step in the digestive system before the content goes out through the anus. And that was the general structures of the large intestine. The next thing we're going to talk about in this video is the layers of the large intestinal wall. So now, if we take a small section of the large intestine and look at a histological picture, you will notice the same general layers just like the rest of the gastrointestinal tract. There's the tunica mucosa, and beneath that there's the tela submucosa, then there's the tunica muscularis, and the outer layer is the tunica serosa. So it doesn't really differ from the rest of the tubes in the digestive system, but it has some characteristics that are special for the large intestine, and we're going to highlight these differences as we go through the layers. So let's focus on the tunica mucosa first, the inner layer. The mucosa of the colon is lined by simple columnar epithelium with a thin brush border. And if we take a small section of the mucosa and zoom in, you will see that we have a large number of goblet cells secreting mucus for lubrication. Note that there are no pleza or villi, which remember were on the small intestine. Instead, there are these straight intestinal crypts called the crypts of Lieberkühn, which are just tubular glands secreting mucus. And between the crypts, there are the lamina propria, with many cell types, including plasma cells and lymphocytes and macrophages, can be seen here in the lamina propria. Then there's the lamina muscularis at the bottom, typical mucosa structures. Now there's no pleza in the large intestine, but instead there are other folds called the semilunar folds, and they're well developed in the colon, but there's some slight lack of them in the caecum, and they're entirely absent in the appendix and the rectum. Now the tunica mucosa of the large intestine has some solitary lymph nodules within the lamina propria, just like the small intestine. But in the appendix, you will find these lymph nodes being aggregated together, forming what is called the aggregated lymph nodules. And therefore, because they're aggregated together, we sometimes call the appendix for the abdominal tonsil. And so another structure that the mucous membrane forms are, at the rectum, remember the rectal ampulla is here, and the mucous membrane below the rectal ampulla form these transverse folds called the transverse folds of the rectum. So we have the superior transverse fold, the middle transverse fold, and the inferior transverse fold. And down here, the mucous membrane form these columns called the anal columns at the anal canal. And between them, the mucous membrane forms the anal sinuses between each column. So that is the tunica mucosa. Next, we have the tela submucosa. So if we take a small section of the tela submucosa, we will see that it contains blood vessels. So here on the right, we see a vein, and here on the left, we see an artery, since arteries are thicker than veins. Arteries are thicker due to their layers. You will find nerves here in the tela submucosa, and a lot of connective tissue. And it's basically the same along the large intestine, except at the anal canal. So remember, the anal canal is here, right? And on either side of it, you'll have something called the rectal venous plexuses, or sometimes called the hemorrhoidal plexuses, consist of a high concentration of veins. These veins form an elevation at either side of the anal canal called the hemorrhoidal zone, which is normal. If the hemorrhoid plexi become enlarged, they can get pushed out, as you see here, and they can protrude externally or internally and cause symptoms like a sudden perianal pain and perianal mass if they're external hemorrhoids. And there are various risk factors for developing this, like an increased intra-abdominal pressure, or pregnancy, or obesity, to even heavy weightlifting. They often resolve by themselves though, and only cause symptoms for a few hours to days to some weeks, depending on the severity. So that is the tela submucosa. Next we have the tunica muscularis, right here, consisting of two parts. The inner layer being circular muscle fibers, and the outer layer being longitudinal muscle fibers. But the longitudinal muscle layer does not continue over the whole surface of the large intestine. There are some bands located on the surface of the large intestine that is formed by the longitudinal muscle fibers being bundled together. And they're called taenia coli. So we have three different types of taenia coli. We have taenia libera, taenia aumentalis, and taenia mesocolica. Taenia libera is highlighted here in red. It's placed anteriorly in the caecum, ascending, descending, and the sigmoid colon, but is placed inferiorly at the transverse colon. Libera means free or not restrained, meaning this taenia is not bound to any structures on the peritoneum, like the other two are. And we'll talk about this in detail when we talk about the peritoneum, so that this video doesn't get too long. But the next one is the taenia aumentalis, which is here in green. The taenia aumentalis is bound to the greater omentum on the transverse colon, and is therefore named after that. On the other side, on the back side, you will find the taenia mesocolica in blue. It's called the mesocolic taenia because that's where the transverse mesocolon is attached to, binding the transverse colon on the posterior side to the posterior abdominal wall. Now these muscular bands, the taenia, are shorter than the intestine itself, and because of that, they pull the large intestine closer, forming these saculations you see on the surface called haustra colli, which are these bumps you see grossly. And between each bump, you will find some grooves called the lateral grooves, which correspond to the semilunar folds. Remember we talked about those earlier? So one groove here is going to be one semilunar fold. So that was the longitudinal layer. Now the circular layer will form sphincters. and the sphincters it forms serve one of the most important functions in the body, and this sphincter lies at the anal canal, and it forms the internal anal sphincter, which is involuntary, and it forms the external anal sphincter, which is voluntary. So that is mainly the muscle layer. Now lastly, we have the tunica serosa, which is right here. Now remember I said that the peritoneum grabs the intestines and surrounds them and fixates them to form this serous slippery surface called the tunica serosa. Here you see a picture again that kind of visualizes that. So this is a transverse cut of the abdominal cavity. The intraperitoneal viscera are the ones that are completely surrounded by the peritoneum. So completely surrounded by this tunica serosa. And these include the caecum, the appendix, the transverse colon, the sigmoid colon, and the rectum. And then you have the mesoperitoneal viscera, which are only partially covered by the peritoneum, as you see here, only by 3 different sides. So that means that these have the tunica serosa on only 3 different sides. And on the last side that are not covered is covered by the tunica adventitia, or tunica fibrosa, which is a fibrous layer. Now the mesoperitoneal viscera include the ascending and the descending colon, and also the middle part of the rectum. So that was everything I had for the large intestine. I really hope this video helped you to understand the complete anatomy of the large intestine. The next video is going to be about the rest of the accessory structures, which are the liver, the gallbladder, and the pancreas. If you found this video helpful, please put a like, share, or comment, whatever you find convenient to you. See you next time.